Afternoon, everyone, and welcome to the Kirby seminar series, a special series today celebrating World Hepatitis Day, which is actually tomorrow. And I think we all know it's a pivotal time in terms of the hepatitis response in Australia. We've got a great program of speakers and then a panel at the end. But I'd really like to start by acknowledging the traditional custodians of the land on which we gather today. Where I am in Randwick, the Bidjigal people of the Eora Nation, and pay my respects to elders past, present and emerging. I'd also like to extend respect to Aboriginal and Torres Strait Islander people joining us today and acknowledge the burden of both hepatitis B and hepatitis C among our Indigenous populations. Just a bit of housekeeping to start off with. The format for the seminar will start off with 4 presentations, followed by a 30-minute panel Q&A at the end. To ask a question, click on the Q&A icon. That's not the chat icon, but the one next to it, on the Q&A icon, to open it up. When you ask a question, please remember to write your name. This will help us reference your question and in terms of answering, making it easier. Okay, so really a great pleasure to introduce Behzad Hajarizadeh, who's a senior lecturer in our program, the Viral Hepatitis Clinical Research Program at the Kirby Institute. He trained as a medical practitioner and has a master's in public health and a PhD in clinical epidemiology. His main area of expertise is viral hepatitis, with more than 15 years experience as a clinician researcher in the field of liver disease. So it's a great pleasure to have Behzad give us some major findings from the SToP-C trial, which is really the basis of the whole sort of seminar today. It's been a pivotal study for us at the Kirby. It's been a really key study, we think, for not just national hepatitis C response, but international responses. So we've got a series of these presentations which will outline different aspects of prevention and management of Hep C in the prison setting. So thanks very much, Behzad.
Thank you very much, Greg, for introduction. And this opportunity to present our work here. I'm going to just give you an overview of SToP-C study, which is hepatitis C treatment and prevention evaluation in the prison setting. Let me just start with acknowledging the theme of hepatitis C. Actually, this is a very big project with lots of partners and people who work on that. The investigators, particularly Greg and Andrew Lloyd as the PI of the study, Marianne Byrne as the study coordinator, and also the protocol steering committee. You can see the list of them. There are many of them to name. Particularly, I thank Stuart Loveday as the chair of the steering committee, and also all the site research coordinator, the SToP-C nurses. And I should also acknowledge that SToP-C was supported by an HMRC partnership project grant and also by a grant from the Gilead Science and all the study partners that you can see in the slide. A very brief background. We all know that people who inject drugs and people who are incarcerated are key population at risk of HIV infection. Treatment as prevention initially used in the context of HIV therapy, and it actually incorporates treatment as a tool for limitation of spread of an infection. And in this particular study in SToP-C, we hypothesized that by rapid DAA treatment scale-up in prison, we would be able to reduce HCV reservoir and also the chain of breaking the chain of HCV transmission in the prison. And in this presentation, I will just give an overview of the study, SToP-C study. I will present the findings of HCV incidence pre and post-treatment scale-up, and also I will present some findings about the DAA treatment coverage and outcome. There were 4 prisons as SToP-C study sites, 2 maximum security prisons, both of them, they were male prisons, and 2 medium security prisons, 1 male and 1 female women prison. Uh, all prison inmates over the age of 18, they were eligible for enrollment. Then there was no exclusion criteria based on HCV infection status, injecting behaviors, or any sentence or remand status. At the enrollment, all of the participants, they were tested for HCV, and then they categorized in 3 groups based on the HCV test results. If they were HCV antibody negative, or if they are antibody positive RNA negative, it means that they were at risk of HCV, either primary infection or reinfection. Or the 3rd group, which in the red color here, they were HCV RNA positive people who were HCV infected. And the first 2 groups, they were tested every 3 or 6 months to evaluate the incidence of HCV. And the 3rd group, who were HCV RNA positive people, they referred for HCV treatment. In the initial phase, before treatment scale-up, treatment was provided through the prison health services. And in the 2nd phase, we provided treatment through SToP-C, which was 12 weeks sofosbuvir velpatasvir. The study started from late 2014. Then the first phase, which we called it pre-GA treatment scale-up, was until about mid-2017. And after that, we started a treatment scale-up period, which continued until the end of 2019. This is the flow of the study participants. That's very small, that I just zoom in. 3,691 patient participants, they were enrolled. 719 of them, they were HCV positive at the enrollment, 19% prevalence. And among these 719 people, you can see that more than 50% of them, they had no follow-up visit, mainly because of the release from prison or transferring to another prison. 416 people, they had at least 1 follow-up visit, and among them, 70% of them, they started treatment, 340. I just go back to the treatment in the next slides. But in terms of the HCV negative people who were at risk of incidence, we had 1,643 people who had HCV RNA negative during the follow-up, and they actually contributed to the analysis of the incidence, with a total person years follow-up of 1,818. Okay, just a quick look at the demographic or basic characteristics of the participants. 82% of them, the majority, were men, as expected. The median age was 33 years, and 27% they were Aboriginal or Torres Strait Islanders. About 50% of more than 50% of the participants, they had a history of injecting drugs, with 22% they injected in the previous month in the prison. And in this group, in the people who had actually recent injecting drug use, the majority, the large majority, over 90% of them, they had experience of sharing injecting equipments in the prison in the past month. Okay, this is the HCV incidence during the study. As you can see here, we had a kind of increasing trend in incidence before treatment scale-up, with the average of 8 per 100% years. That's before treatment scale-up. And after treatment scale-up, the incidence decreased to 4.3 per 100% years. And this is a regression analysis that you can see. The dotted line, the red line is the predicted HCV incidence in case there was no intervention. And the solid red line is the observed incidence. And you can see that obviously there is a reduced incidence during the study period. And in terms of the incidence rate ratio, then we had about 48% decrease in the incidence of HCV between 2 periods, which was statistically significant. And it is about the whole population, the total population. And if we can look at the subpopulation who had experience of injecting or reported injecting in the prison, you can see that the impact was even larger, about 60% decrease in the people who had history of injecting but not in the prison, and 53% increase in risk among the people who had injection in the quarantine prison. These results has been published in the Lancet Gastroenterology Hepatology. If you want to, if you're interested in more detailed study findings. Okay, in terms of the treatment, as I said, 719 people, they had HCV RNA positive at baseline. And as you can see, 44% had genotype A, 43% genotype 3, and the large majority, they had mild liver fibrosis. The fibrosis stage was 0 to 2, and only 2% of participants, they had cirrhosis. There was no HIV co-infection cases, and 6 participants with HBV co-infection. In terms of the flow of the participants, as I showed in the previous slides, more than 50% of HCV RNA positive people at the enrollment, they did not have any follow-up visit, mainly due to release from freedom or transferring to another prisons. And among the people who received treatment, which 340 people of the HCV RNA positive people and enrollments received treatment, and also 9 people with incidence HCV during the follow-up, they received treatment as well. Then in total, a total number of 349 people, they received treatment, and you can see that the majority of them, they were through SToP-C, and just a small proportion, they received treatment through the prison health services or in the community during the time that they were released. Then if you look at, you can see in this figure, after actual treatment scale up in SToP-C, the majority of the people received treatment, they were through SToP-C. And yeah, and in about the treatment outcome, among 324 people who received treatment through SToP-C, only 65% of them, they stayed in the prison until the end of the treatment, and actually they completed treatment. For the people who transferred to the other prisons or the people who released, all of the treatment course, they will be provided to the participants at the time of exit from the prison. And but they were not included in this study. Then for the people who released, they were also provided with a referral letter to a GP. And also for the people who transferred to the other prisons, also all the treatment documents, they were just handed over to the other prison. But in terms of the data, the treatment outcome, we did not have any treatment outcome of those people who left the prison. And among these 211 people, 143 of them, they stayed in the prison post-treatment and they had a SVR assessment. And in this population, 137 of them, which is 96%, they had SVR. They had 2 virological failure and 4 reinfection. And that reinfection is during end of treatment to SVR. I was going to present other data or more detailed data of post-treatment HACV reinfection, but the data needs still a little bit of working on to be accurate, and I did not present here. Then, in conclusion, yeah, SToP-C study was the first HACV treatment as prevention study in the prison, and actually it was the largest in any setting. And the study demonstrated the strong evidence of the impact of HACV treatment as prevention with actually decreasing HACV incidence by 50% actually following rapid DAA scale. And we showed that the magnitude of HACV treatment as prevention was even larger in the participants who were at a greater risk of HACV in the prison, who were the people who reported injecting drugs in the prison. And the combination of a rapid DAA scale up and other HACV prevention strategies, they are likely to provide even larger impact and greater impact on HACV transmission in any high-risk setting. And yeah, I'm just, my last slide is not related to SToP-C, but I think you are aware of these newsletters that we released. We are going to release the new issue probably by the end of the week. And this is the URL, the link that you can find the new report, and we are committed to release that by the end of this week, hopefully. Thank you very much.
Thanks very much, Behzad. A great sort of overview of the SToP-C study to get things started. When we sort of ventured into this area in terms of Hep C prevention among people incarcerated, there clearly were some concerns about whether people would come forward due to issues around Hep C reinfection because of the lack of access to safe injecting equipment in this setting. So it's great that we've had some work in terms of social science looking into this issue. It's a real pleasure to introduce Dr. Lise Lafferty. He's a research fellow with a co-appointment across the Centre for Social Research in Health and the Kirby Institute. Lisa's research interests include people inject drugs, including those in prison and the community, bloodborne viruses, sexual health and Aboriginal health. She has a community background working with diverse disadvantaged communities, including people with disabilities, young people at risk of entering the criminal justice system, and Aboriginal communities. So it's a great pleasure to welcome Lise. Thanks very much.
Thanks, Greg. So yeah, I'll be talking about the experiences and perceptions of treatment as prevention, both pre and post treatment within the prisons where SToP-C was done. There we are. So just some acknowledgements. First, I would really like to say thanks to both Greg and Andrew for having me involved in this work. My PhD focused on Hep C treatment uptake in the prison setting during the tail end of the interferon era. So being able to come in and do this work around DAAs was really exciting. I'd also like to acknowledge the other qualitative members, team members, Professor Carla Trelaw, my boss and amazing mentor, and Dr. Jake Grants, who was an incredible confidant throughout this work as well, and to the many, many participants who contributed their time and knowledge and expertise for the qualitative work. I'm not going to go on the background too much because Behzad really covered that, but in Australia, a majority of people who enter into prison have reported at least injecting drug use at least once in their lifetime. And it's important to note that direct-acting antivirals are available under universal healthcare within Australia, and that's a key thing that'll come up later on in my talk. But for the purpose of this study, it was the Hep C treatment was provided by Gilead. So we did qualitative interviews with people in prison, both pre and post-treatment scale-up. It was just sort of random that I happened to interview one of the same people both times, and we remembered each other, but that wasn't the intention. We also did interviews with prison-based health, corrections, and study personnel. And then Jake led the expert stakeholder interviews. But today I'll be focusing on these first two, the people in prison. So just an idea of the people that I interviewed pre and post-treatment. You'll notice in the pre-treatment interviews, I did 8 interviews across each of the 4 prisons. And then the intention was to do something similar in post-treatment interviews. But as Behzad highlighted, as people were coming near the end of treatment, they were leaving prison. And then to do SVR 12 interviews was even longer. So with the women's prison, where they often serve shorter sentences, and men in the lower class security, it was really hard to access those people. They were often gone. So I did interview one female in the post-treatment interviews, but we ended up excluding her from any of the analyses just to ensure her confidentiality. And then in the pre-treatment interviews, I interviewed people with a whole range of experiences. So people who did have active Hep C infection, those without, 2 who were awaiting their results, and then people who were receiving or were not receiving OAT, as well as people, everyone had a lifetime history of injecting drug use, but people identified whether or not they were current or non-current use of drugs in the prison setting. And then in the post-treatment, I interviewed, everyone had been cured of Hep C, so that's a difference in the post-treatment interviews. But I did interview one of those people that Behzad mentioned who had become reinfected, and that person had already started their retreatment by the time that I met with them. So some pre-treatment findings. I always found it interesting that people have this assumption that people in prison may not comprehend treatment as prevention as this complex stuff, but people were really insightful. And I think it's important to highlight what they perceived as might be some of those challenges of treatment as prevention. So this guy explains there's no point getting on treatment if you're still going to use, because eventually you're going to contract it back again. So it's pointless doing it, really. And someone else explains it's just sort of delaying a losing battle. And that became the quote of this paper, was actually fighting a losing battle from another participant. But there was real skepticism amongst people in that pre-treatment surveillance stage. And here they talk about why those issues are there. So this first person explains, if someone gets out, so they leave prison, they come back in on a new charge, or they change prisons, you're just going to be chasing your tail. It's just purely not going to work. Too many people in and out, in and out. So they get treated in prison, they leave to community, perhaps get reinfected in community, and then come back into prison. And so then this next quote really highlights the social situation in which that risk happens among injecting networks in the prison setting. So and he argues that you have to treat the whole system. So don't just treat 4 people in 4 prisons. You have to treat everyone in the correctional system, because someone goes out, someone comes in, you've known them for years, it's your mate from since you were little, and he's going, hey, how you going, mate? And that person has Hep C, they bring it into that network of people, and so then everyone that has been treated is then suddenly at risk of reinfection. And he said, so that's the logistics. And some post-treatment interviews, and I just want to reflect on this because I think this was so important to understanding some insights into what people were experiencing during that post-treatment stage. So pre-treatment, I went in and I asked people, so when was the last time you injected drugs? And people would tell me, this morning, yesterday. And people were very forthcoming with that information. So forthcoming that I wrote a whole paper on how does hepatitis C factor into who goes first amongst an injecting group of people, an injecting network in prison. And so then I really had to reflect and go, okay, the first day I went in and I was doing these interviews and saying to people, when was the last time you injected? And literally people were covering their mouths as they answered to me, or really getting quiet in their response. And so it was clear that they didn't want to share this information. I couldn't figure out why. So I did some reflection and thought about it. And what became apparent was that people were so concerned that they were wasting this, this study had come in and invested in them and cured their Hep C. I mean, what a wonderful opportunity. And now without opportunity to prevent reinfection, people were embarrassed and ashamed to have that conversation that they were potentially at risk again for reinfection. And so in that, it also became apparent to understand that people didn't know that they were eligible for reinfection. So there was this lingering interferon sort of an understanding that you get treated once and that's it, you're done, that's your opportunity. Whereas now, as I said, the universe of the national healthcare, you can just get retreated. And that was an important thing to communicate to people early on in the post-treatment interviews. All that said, people still had concerns that there was expectation that they maintain their cure status. And this guy says to me, I don't want to be one of those people who talks to you, meaning post another treatment round in another 6 months. It would embarrass me. And so he's using Finkel, whatever's available to him in prison, but he wants what's best for him. And then there's someone else, when I asked him, why did you get treated if you thought you might be at risk again? He said, there's a chance that I won't use again and I'm clean. And then again, that elimination equals treatment and prevention carried forward into the post-treatment interviews. And there was a lot of talk about needing to get people involved in both the treatment, the Hep C treatment, but also other elements of being able to manage their drug use within the prison setting, so that it wasn't just focused on the Hep C treatment. And then someone else who did not report current injecting drug use explained that prevalence in the prison setting itself was a risk factor. And so for him, fighting could potentially expose. So for him, it was very important that everyone else had been treated because his likelihood of getting reinfected through a fight then became much lower. And just to highlight, in the post-treatment interviews, whilst there were concerns about reinfection and concerns about maintaining this cure status, there was a lot of support for people coming forward and supporting their peers to get tested. I mean, it was wing wide in some of these prisons. And this guy explains that conversation that he had with a mate, saying his mate said to him, I won't do Hep C treatment until I'm ready to get out. And he explained, but if something happens, you can do it again before you get out. You can get retreated. The idea is to get rid of your Hep C so that you don't catch it again. And so this guy was thinking, I don't get out for 12, 13 years. I'll just wait. And then Rick is explaining to him, but that is you giving it to everyone again accidentally. So he's really, there's a lot of communication that's happening amongst peers within prison to help tailor the messaging. So just in conclusion, there is broad understanding of treatment as prevention. There's ongoing concerns that it needs to be this sort of dual approach. And the expectation to retain cure was very much self-imposed. I don't think people viewed it as being imposed upon them, but they had this sense, this responsibility that they were supposed to keep their cure status. And there was definitely broad support for hepatitis C treatment scale-up. But I think going forward, it's really important that health promotion and education messaging really highlights to people that they are eligible for retreatment should that need be. And so just lastly, to draw your attention to some other work that we did within the SToP-C qual phase, and then specifically these papers include elements of reinfection with them as well. Thank you.
Thanks very much, Lise. It's great to have such a multidisciplinary team to sort of be involved in SToP-C. It's been one of the great sort of pleasures of working on the program. Now we're going to move to how to sort of implement this. So we know that rolling out hepatitis C treatment, scaling it up in high-risk settings can certainly have an impact on incidence of transmission in those settings. So it's great to have Andrew Lloyd, who's really been an absolute leader, not just for this project, but in Australia and internationally in terms of strategies for both prevention and treatment of hepatitis C in incarcerated settings. Andrew is a clinician scientist, infectious diseases physician at the Kirby Institute, and he'll be giving us an overview of the SToP-C implementation toolkit. Thanks, Andrew.
Thanks so much, Greg. I'd like to introduce you and encourage you to take the opportunity to have a look at an interesting endeavour we embarked upon in association with the larger SToP-C study, and that is to try and bite the bullet, to try and give guidance beyond the 4 individual prisons that participated in this carefully controlled and well orchestrated controlled trial. And that is to try and face the challenge of getting the message out across the prison sector nationally and across the prison sector internationally. And the background to that incentive is that it's unequivocally clear that Australia really is a world leader in the elimination effort, and in particular is a world leader in the prisons elimination effort. And so the challenge that this toolkit starts to face is how to spread the message beyond our relatively narrow clinical trial boundaries. And the backdrop to that thought comes from the fact that even though there are 194 countries internationally that have signed up to the WHO elimination goals, in this report from the WHO, which was 2019, there were only 124 countries that actually had a viral hepatitis testing and treatment plan. That is to say something about how they would address the elimination effort. So that's a minority. And then of that minority, there were only 51, so it's 41%, that actually had a specified intervention for the premier risk group, that is people who inject drugs. And of those, only 28 actually had a proposed plan to do something about the correctional environment. That's despite the fact, as both Behzad and Lise have flagged for you, that there's an inevitable cycling of individuals from the community to the prison and return. And so that is a substantial challenge in spreading the message. In addition, highlighted to some extent within SToP-C, but definitely true globally, we have a situation in the prison context where the harm reduction strategies are not as good as they are in the community. And so in a very generous estimate of how well this is working globally, there are only 54 of the 194 countries that are signatory to the WHO elimination effort that have opioid antagonist or agonist therapy in the prison environment, in at least one prison of the country's prisons, and only 8 countries that have a needle and syringe program in at least one prison of the many prisons typically found in each country. So you can see there is a substantial need not only to build the evidence base for improved prevention strategies, but also to spread the word about the potential utility of those interventions. We're lucky enough in the SToP-C research team to have a collaboration with the New South Wales Ministry of Health, and in particular to have a collaboration with something of an expert in the business of scaling up, that is disseminating effective population health interventions. That's Andrew Malash. And he actually has written a guide for how you should do this. And so I've stolen a little bit of material from his guide. And so you can see the notion of scaling up is this deliberate effort to increase the impact of successfully tested interventions to benefit more people by fostering policy and program development on a lasting basis. And so in his guide, Andrew talks about 4 steps, just to make it sound relatively simple, but each of those steps actually has got a whole lot of devil in the detail. On the far right, though, is the first step, which is to actually really show the evidence, demonstrate effectiveness and the potential reach of that intervention. And so my sense is that you'll, given Behzad's presentation, that the SToP-C trial has established that. It's halved the incidence. The qualitative data that Lise has referred to helps us to understand things like acceptability and feasibility by interviewing all of the key stakeholders. We haven't spoken about the modelling and cost effectiveness studies, but there are a series of these studies which seek to demonstrate the benefit of scaling up across the state is the model in the first instance that's in progress, and how much of a cost it would impose and how much benefit it would provide and cost savings, which we feel confident it will demonstrate. So with in the near future having all of those elements in place, the next step is to spread the word. And so the way we've proposed, or the way we're embarking upon trying to do that, is with the SToP-C implementation toolkit. And we thought carefully about how to do this and have landed primarily with a website, which, as I'll describe for you, highlights some of the challenges, the barriers, the opportunities, lessons learned from the process of doing the SToP-C study for subsequent service delivery across the country and potentially across the globe. So we embarked upon this in a systematic fashion, firstly by developing what we called an issues register. That is, working out what are these barriers and challenges and obstacles. And that involved regular interactions with stakeholders, correctional authorities, health authorities in the prison sectors, consumer representatives, undertaking some of that qualitative research that Lise has referred to. We were lucky enough that Lise and Carla Treloar, shortly prior to the SToP-C study, had done a policy review, not only for New South Wales, but across the country. So we had a pretty good understanding of the policy settings and framework across the country. And then I've alluded to the modelling and cost effectiveness studies. And so we undertook this process throughout the SToP-C study. The most arduous of those, but in some ways the most informative, was this thing that I alluded to called the issues register. That's where every problem that arose that we thought, oh my God, what a nightmare, how in hell are we going to overcome not enough correctional officer staff to help bring the patients up to the clinic? How will we resolve the challenge of not enough pharmacy capacity? You name it, we faced those challenges and to a reasonable extent resolved resolutions. And then we coded all this data in real time to understand those issues and their impact and the solutions where we found them that we were able to implement. And so that body of information led to the toolkit, which I'm going to show you on the website in a moment. But just to give you the big picture, to help you to encourage you to take the opportunity to have a look at the website. So we described the planning and implementation issues and the recommendations that came from each of the target audience, to stakeholder audience members. We formatted a website and developed a PDF manual that's available for people to download and distribute and refer back to. We interacted with policymakers, correctional authorities, prison health service administrators, prison management, and developed a website with all of those materials that I've alluded to. The website, when you come to have a look at it, and I'll illustrate for you in just a sec, involves the target audience of the website, I should say, are indeed higher level administrators, either in the prison health sector or in the correctional sector, to give them guidance on, if you were thinking of doing a treatment scale up as a prevention strategy, how would you go about it? And so it's got broad components that orient towards those two target audiences. And it's got what you might call an executive summary kind of format. So it's got a quick tour, and then it's got a detailed blow by blow, this is how it should be done. And we used a lot of those materials that we've heard about from Lise and from others to take quotes that were informative for various elements of the implementation plan, to highlight in these darker green boxes some of the lessons learned. So for instance, I've landed here on one of the lessons learned, and that is that just the dispensing of all the DAAs actually imposed a large impost on the pharmacies and the nurses in the prisons involved. And at the time the study was initiated, a lot of inmates actually, or the majority of inmates, had to have directly observed administration of their medication daily. That's a lot of movements of inmates from the cells or the wings up to the clinic, get the pill, go back, correctional officer to escort them. And so we championed the notion that with an appropriate triage risk assessment for each individual, inmates could self-administer by getting a weekly or a monthly pack of the medication. I'm going to stop the slide set here just by, in particular, acknowledging the implementation subcommittee, which involved Marianne Byrne, the project coordinator, and myself coordinating a team of interested parties and key stakeholders, and re-acknowledging the funding. This project, this sub-project, was also supported by the NHMRC grant and the Gilead support. And I'm going to now take you to the website just for a very brief couple of minutes overview of the website. So in the toolkit, as I flagged, there are graphics and colour schemes that have cogency with the prison environment. And the opening page highlights the fact that there are materials within that are for correctional authorities and for health authorities. And then there is a quick tour and a more in-depth toolkit. And so if we start with the quick tour, which is the high-level tour, you can see that there are sort of executive summary documents that provide an overview, some planning, some implementation, some evaluation, and dissemination summaries that are sort of illustrated here. So if I take you down, walking your way around the website here into the planning, for instance, and then we drop down into the more detailed component of the planning element, you can see that if we, for instance, go to understanding the prison environment in the planning phase, what we learned is that it is important to understand what we call the access restrictions. How well can a health service interact with inmates when they're in lockdown or they're only allowed a certain amount of time out of their cell? And similarly, you know, what do you do when you're competing with the dentist and the psychologist and the Indigenous health worker to give some pearls of wisdom or provide medication to the patient? So managing those logistics were a couple of the things that we learned. And then if I jump across to the implementation page and have a look at some of the things that we learned, and we drop down for a moment into the correctional authorities implementation, we looked at and considered how the access or the availability of correctional officer time to bring people up to the clinic for their healthcare interactions. And we decided that it would be a good investment to get a dedicated officer for this role to facilitate the scale up. So those are just brief examples of some of the key lessons learned. And the website, if I just jump across, has also got some other key insights. That is some of the terminology that's relevant, both in a health sense and in an in-prison jargon sense that are important to help understand the prison environment and how it works. And the website also has a great list of resources ranging from pro formas to checklists to communications to disseminate the strategy, access to a lot of the publications that Lise and others have referred to. So I'm going to stop there and just again to re-acknowledge all of the key collaborators that have participated in the development of that toolkit. Thank you so much.
Thanks very much, Andrew. And I'd just like to join in acknowledging the amazing support we've had for the SToP-C program, and particularly Marianne Byrne has been an absolute joy to work with in terms of driving this project, and the research nurses that staffed each of the prison settings, as well as prison officers that worked with the project. It really was a very large endeavour over several years, and hopefully will drive some strategy going forward. I think one of the things that everyone acknowledges is that there is ongoing transmission, even though Hep C treatment does reduce incidence. And we need to sort of get better at the prevention side in addition to just the therapeutic intervention. So it's great to have Adrian Dunlop, who's a addiction medicine senior staff specialist with the Drug and Alcohol Clinical Services in Hunter, New England, and a conjoint professor at the University of Newcastle, who's going to give us a presentation that looks at expanding opioid agonist therapy through depot buprenorphine. Thanks very much, Adrian.
Karai anti-parai awawakal katanian parai awawakal umba. I'm talking to you from a Awabakal country. I'm up here in Newcastle, New South Wales, and I'd like to acknowledge the traditional owners of the land that we're on and the elders past, present and emerging. There's my disclosures. I'd like to acknowledge the co-investigators on this study, in particular, Beth White for fantastic coordination of the project, and Jill Roberts from Justice Health, and Nick Linzeris and Paul Haber, and of course all of the clinical staff and the research staff and the participants at the different sites. I'm going to try to just give you a nice quick synopsis, so hopefully we've got a bit of time to chat at the end. The point of this presentation is to look at hepatitis C from another perspective, and that is the relationship between having access to opiate treatment in prisons and that as an important way to try to reduce hepatitis C transmission risk by reducing injection risk in custody. So under treatment of opiate dependence in prison has been a long-term problem in New South Wales prisons. In this study in particular, we decided to enrol a group of participants who had a history of opiate use, who may or may not be current opiate users in custody, and compare that to a group of stable patients already in methadone treatment, already stabilised on methadone treatment. So it's not a like-and-like comparison. There's some important differences between the two groups. So this was prior to the previous listing of depot buprenorphine, or bupidiol was the product we used in this study. We tried deliberately not to over-select the patients, so essentially they had to have a history of opiate dependence, and there are a couple of other exclusion programs, including programs that required them to be abstinent and not on treatment, not on opiate treatment. The primary outcomes were safety and tolerability, and also in particular to look at diversion or non-medical use of depot buprenorphine in its introduction into New South Wales custodial settings, and also to look at costs. There's some other outcomes I'll talk to you about today as well. So methadone standard care, generally high dose methadone in prisons. For the buprenorphine arm, we gave participants a single sublingual dose of 4 milligrams. It could be repeated on other days. And then typically after that dose, and that was really to test that people did have current tolerance and weren't going to become over-sedated from being given buprenorphine. They were given 4 weeks of weekly depot, starting at 16 milligrams, but could be titrated up or down. And then 3 months of monthly depot, jumping up to 96, but could be titrated up or down as required. In the depot group, 80 were enrolled, 80 were assessed for eligibility, 69 screened, 67 enrolled, 64 completed week 4 and 59 week 16. If you look between the two groups, and again, just remember they're not directly comparable. The methadone group already stable in treatment. You can see the depot buprenorphine group slightly younger, about 4 years younger. That age sort of equivalent to what Behzad was talking to us before in the SToP-C cohort. Generally male, Australian born. We tried not to under-enroll Aboriginal participants and were successful. The methadone group's slightly heavier than the depot buprenorphine group. This is one of the things I want to point out. So if you look at hepatitis C antibody positivity, you can see it's high in both groups, somewhat higher in the methadone group, but RNA positivity much higher in the depot buprenorphine group. And that's driven by their ongoing risk of injecting in prisons. So the study was mainly a safety study. We commonly saw adverse events, but I'll tell you a bit more about their nature. Serious adverse events were uncommon. So there were 2 in the depot buprenorphine group. One was a case of serious self-harm, and another one I'm just about to describe to you in a moment. But you can see of the side effects reported, overall mild. They were nearly all mild, some were moderate. We didn't have severe AEs. And there were things like injection site pain, constipation, injection site swelling, headache. These sorts of reports gave us confidence that we were engaging well with the treatment population and were getting a sense of what was happening for them. The other SAE in the depot group was a patient who developed hepatitis C. So this was a patient who'd been, a 36-year-old guy, had 3 times previously had hepatitis C, twice cleared spontaneously, once been treated with DAAs, and had a long history, 8 years of injecting up to 4 Suboxone strips, 8 milligram strips a day. At screening for the study was Hep C PCR positive, wasn't able to be genotyped. And then after 3 weeks of depot treatment, developed an acute icteric hepatitis illness, ended up being in hospital. You can see he had a transaminitis, was transferred back to methadone because we weren't confident at that stage to continue him on depot buprenorphine treatment. His LIFTs normalized and spontaneously he cleared hepatitis C 1 month later. And the opinion of the hepatologist was this was likely to be caused by an acute hepatitis C infection, not by a bolus dose of depot buprenorphine, because there are case reports, of course, of high dose buprenorphine causing hepatitis. Other key finding, diversion of depot buprenorphine, both objective and subjective, was not reported at all during the study. In terms of costs, you can see the costs of depot buprenorphine in terms of the sort of staff costs is much less. These are monthly costs compared to methadone and sublingual buprenorphine being much more expensive. And then when you add the costs, the costs of medication to the government, depot buprenorphine and methadone are somewhat still similar, but sublingual buprenorphine is of course more expensive, and that's mainly driven by the time required for supervision in a custodial setting. Retention was high, and this is really what's driving that issue I was talking about before. We aim to enroll people who had a history of injecting opiates in prison or were currently injecting. Nearly everybody was injecting at baseline. You can see across the 3 time points that dropped off very significantly over the study. That's the proportion and that's the number of days. So injecting nearly every day and that dropping down to much less at week 4 and week 16. Patients were also highly satisfied with the medication. So we were happy that we were able to implement this study and show that you could safely implement depot buprenorphine in a range of minimum, medium, maximum security prisons across genders and with a high proportion of Aboriginal people involved. A key thing is, because we didn't know a pandemic was just around the corner, the pandemic was just around the corner, and very effectively Justice Health rapidly switched to depot buprenorphine. You can see from March, April, essentially they stopped providing Suboxone. The dark orange number is the proportion on slow release or depot buprenorphine. The methadone number has trended down and the total number in treatment is about 1.5 times what it used to be. So that's, in terms of a policy success, that's been a fantastic policy success. And we've recently just published that. So that's the end of my presentation, and we should have a few minutes, Greg, for questions for the panel.
Thanks very much, Adrian, and thanks for getting through that really swiftly. So look, that's the end of the 4 presentations. So we've got plenty of time now for our Q&A session. So we're going to have the presenters join the panel, but it's a great pleasure to also have Stuart Loveday and Tracy Brown joining the panel. Stuart is someone who's been involved in the SToP-C from the start. He was the chair of our SToP-C steering committee, so we're really pleased that he can be involved today and very, very thankful for the role that he played throughout the project. He's also, as I'm sure everyone is aware, the former CEO of Hepatitis New South Wales and still a current board member of the Justice Health and Forensic Mental Health Network. Tracy's a program manager with Population Health, Justice Health and Forensic Mental Health Network. So it's great to have someone who's really involved on the ground, so to speak, to give us her sort of perspective during the Q&A sort of session. So thanks everyone for making the time. There's a few questions that are sent through to us before the seminar today, so I might start with a couple of those. And one of the questions is from Peter Blood of Corrective Services in New South Wales, asking, do you have information about the effectiveness of inmate peer support groups to reduce unsafe practices that place them at risk of contracting hepatitis C in the prison setting? So Andrew, I might throw that to you to kick off in terms of peer support
It's
involved?
probably, to be honest, Greg, it's probably better if I deflect slightly to Tracy, because Justice Health has been in partnership with NDARC actually to implement a peer-based education program.
Perfect then. Yep.
Can you
go ahead, Tracy.
Yeah, hi. So we have partnered with NDARC last year. We ran 2 pilot programs at Long Bay Hospital with the patients there. We're retweaking after the evaluation. We had about 6 people in each group, and from what we've heard, going back and speaking to them, they have actually been out in the yard spreading the word about Hep C and harm reduction and the different treatments that are available to them, and the fact that they can be retreated. We're looking at rerunning those again this year, and we're hoping to actually go to Delwinia so we can actually trial one with women. But so far it's been quite successful, but we're only quite new into the field.
And Tracy, what's your sort of feeling in terms of that involvement with peers around the issue of reinfection? I mean, is there ongoing concern about reinfection? Do you think that's impacting on people's sort of decision-making in terms of Hep C treatment?
Look, I think it is. We do still, even today, we're still getting people coming up to us saying that, you know, they don't want to get retreated. They don't want to get retreated because, you know, they're still injecting, and, you know, what's the point? And, you know, or some that don't even understand that they can be retreated. So, you know, there is a problem there, and that's one of the big things that we're pushing with these peer groups is that, you know, you just come and ask the nurse, there's no problem, you can get retreated anytime.
Okay, thanks very much, Tracy. Any other panelists who want to sort of give us their thoughts around the role of peer support in terms of both Hep C sort of treatment uptake and prevention strategies?
Thanks, Greg. Stuart Loveday here. Certainly, peer support is known to work exceptionally well within the broader community, where it's resourced, and by that I mean funded. The peers are paid, a bit more difficult in the correctional context, but yeah, a big thumbs up to peer support.
In the post-treatment interviews, I mean, there was a lot of peer support in an informal way, so not a formal program, but just people speaking to each other about, in that last quote, you know, you've got to go forward and get treated now, don't wait until the end of your sentence, but also just people coming together and being medication buddy, so to speak, reminding each other who were on treatment together. Oh, my cellie took his medication, that reminded me. And so people provided support to each other in a whole range of ways that I think was useful to accessing treatment, but also treatment adherence.
And Lise, what do you think in terms of the status, you know, in prison at the moment? Do you think sort of people being, or other people potentially being aware of individuals' Hep C status is an issue? I mean, is it something that's stigmatizing in the context of incarceration? Has that been a problem in terms of rolling out Hep C treatment?
So I think there's a lot in that question, Greg. So throughout this study, throughout SToP-C, it was interesting because initially it was Hep C was what was stigmatized, and then it was the injecting drug use that was stigmatized. And so it seems to sort of the social challenges of that sort of shift over time. And I don't know what it is at the minute. I haven't been into prison this year, but I think that's an issue. And I'm sorry, I've just blanked on the rest of the question.
Just around the issue of sort of status and whether it impedes either on the sort of the side of people coming forward for treatment,
yeah,
or in the context, I suppose, of prevention strategies.
Yeah. So people talked about confidentiality could be an issue, and I think there was benefits highlighted. If you're going in and treating or testing everyone, then it's less likely that you're being picked out as someone who definitely had Hep C. People were very, very cautious about coming forward for testing and treatment if they were part of an injecting network where it may be assumed or expected that they didn't have Hep C. So they were terrified to come forward. I see Andrew's ready to answer something.
I was going to quote you one of your quotes, actually, to be honest, Lise, which is somewhere on the Toolkit website, which is a great quote from an Indigenous woman who basically sort of describes a circumstance where she worked out that she had a small, I think, indigenous network of women who are injecting together, and it would be better off if they all got their act together and all got tested and all got treated. And so what I was going to say is that peer-to-peer interaction, it is both an absolute potential positive as well as a plausible barrier.
Thanks very much. It's been a great sort of discussion about that issue. I might just ask Adrian. There's a specific question from Chris Wallace. Hi, Adrian. Is a 1 or 4 milligram Suboxone dose the standard now in New South Wales prisons prior to commencing depot?
Yep, my understanding it is, yes. 1 only, and they're doing 2 weeklies, I think, and then or 2 or even 1 weekly and then to monthly.
So does that differ in terms of community? I mean, is it the same sort of strategy that you would use in the community?
So the TGA listing changed about a month ago, so you don't have to have a run-in on sublingual at all. So you don't need to do that in the community. I guess the context is slightly different of needing to, well, you probably don't actually, but whether you think you need to do a tolerance test of somebody in a custodial setting.
Okay, I might follow that up with another question from Chris to you. Is there a ceiling in regards to the number of prisoners qualifying for opioid substitution therapy in New South Wales prisons? Many prisoners I talk to seem to assume that we could just put hundreds of prisoners in each facility on OST, but this is just not feasible. So
I can't answer the question, Greg. Hunter New England is my principal employer, and I think that's the question for Justice Health.
Any views from any other panelists? Andrew, do you have any insights into that?
Oh, again, I reckon it's a Tracy question. There are person power limits, aren't there, Tracy? You've got to be able to introduce depot bup safely, and that requires some evaluation. And I think my sense from afar is that there's a challenge to have the appropriate and adequate medical and, I guess, psychological assessment to get people onto therapy, but downstream it's less resource intensive. But Tracy, over to you.
Oh, well, look, I'm not drug and alcohol, I'm population health.
Yeah.
All I can say is, they are getting a lot of people on. We have a referral pathway, and so if we get people that are being reinfected with hepatitis C, we actually have a referral pathway with drug and alcohol to get them onto OAS. So that's good, but I can't really, unfortunately, speak on behalf of drug and alcohol. I'm not part of the rollout.
Thanks, Tracy.
Another key thing is we really want to make sure people maintain treatment in the community when they make the transition to the community, and we don't know the answer to that yet. We're interested in finding that out.
Mm.
Greg, just a direct answer to the question about a cap. No, there is no set cap. The limitations of the number of people in correctional settings going on to depot bup is limited only by the finance available and the funding available. So I am aware that the funding was really good in the financial year just gone, 2021, and that it is continuing, but on a one-off basis in 21-22. So watch the space. Very good relationship between Justice Health on the one hand, the Ministry Drug and Alcohol section on the other. So it's been a major boost to capacity in that particular area of harm reduction, but there are many challenges elsewhere, which we'll get onto next, I assume.
Thanks very much.
One other comment, and this is probably sort of something that Adrian might pick up on, but my sense, again, I'm not a drug and alcohol clinician, but my sense is there are some definitional challenges, because opioid replacement therapy works for people who are opioid dependent. And my understanding or my experience in the prison sector is that it's a relatively dynamic phenomenon. So individuals may be polydrug users on the outside, but on the inside, if availability of opioids is better, then that will be the drug of choice. And if you have a definition of an opioid dependent person that somehow covers the period outside as well as inside, they may not cut the muster.
Yeah, look, that's a real can of worms, Andrew. Glad that you've opened it. I'm not going to try to close it in a couple of minutes. Fortunately, you know, we're generally in the community very happy with the assessments that have been done in a custodial setting, and we continue treatment. But you're right, there are some people who choose not to continue treatment when they leave. It's an area that we need to better understand.
Mm.
Okay, the next question is probably one for Tracy from Louise H. What KPIs do prisons have to meet to incentivise them to get prisoners tested and treated for hepatitis C?
We have huge KPIs. Our KPI for this financial year is 1,250 initiations on hepatitis C treatment. It was 1,250 last year. The previous year it was 1,500. So we have huge KPIs, but we get very close to meeting them. I think the year it was 1,500, we did over 1,450 initiations. Last year with COVID, we still managed to do about 880. So whilst we didn't hit the KPI, we're very proud of how many we got to do with all of the COVID duties that were going on as well.
Yeah, I think, Tracy, it should be absolutely acknowledged that you're much, much closer to hitting the KPIs than the community-based KPIs, and that treatment through the prison system, I think last couple of years has been around about 1/3 of the total treatments in New South Wales. Andrew might have sort of better stats around that, but it's an increasing proportion of the total number of people that we're treating at a population level.
Yeah, totally. So I think, to be honest, New South Wales is an exemplar across the country of having KPIs and responding pretty well to them. And across the country, the available data suggests of the order of 1 in 4 or slightly more of every single person who gets DAA treatment actually gets initiated in the prison. So the prisons are totally front and centre in the national elimination effort. But having said, sorry, Greg, but having said that, there is, if we estimate the number of individuals who become incarcerated for a period in Australia, you know, there's about 80,000 individuals put into prison each year. And there's somewhere between, let's call it a 10% on average chronic hep C prevalence. That's a lot of people who are coming into prison who plausibly should get recognised, tested, treated. And at the moment, in very few jurisdictions are they anywhere near reaching that plausible number. So the KPI is great and it's hard to achieve, but there's a lot more space of patients to be recognised, diagnosed and treated.
That leads perfectly to the next question, which sort of asks, will the SToP-C findings lead to the implementation of a new national benchmark or KPI to treat at least 70% of hep C patients in correctional settings? So Andrew, is there any discussion around potentially setting a national sort of benchmark?
Yeah, absolutely, Greg. So it's a great question from the audience here, because as it turns out, the National Prison Hepatitis Network is currently close to finalising what will be the consultation draft of a position statement specifically for hepatitis C testing and treatment recommendations for the prison sector. And it includes recommendations of what sort of testing strategies are best practice and what sort of treatments and so on. But it does also propose a series of KPIs and reporting measures to try and help the national elimination effort keep track of that key contribution. So I'm hoping that the prison sector, so to speak, can put the community sector to shame with how well we organised. We're not quite there yet, but that's my aspirational goal. I think the 70% target actually might be a little bit below what we're actually proposing as the KPI.
That's great. That sort of leads nicely into the sort of next question, because if we're thinking about setting a benchmark and acknowledging the sort of dynamic nature of movements within the prison sort of setting, clearly one of the goals has to be to screen and get people onto treatment more rapidly than has been the case. So Chris Wallace asked, should the federal government be providing funds to roll out point of care testing across the national prison system, considering that they have invested so heavily in their elimination strategy? Is anyone aware of any potential progress on this? Standard blood pathology is simply too slow, and point of care, that should become the standard. So Andrew, maybe follow up with that and maybe a few sort of top line highlights from Pivot.
Yeah, so actually in some ways, Chris and the audience, it's a great advertisement for a forthcoming symposium, which I think is just a couple of weeks away, which is going to talk about a study we've recently completed in the New South Wales prisons, evaluating an alternate testing strategy, basically simply based on point of care testing, fibroelastography, so fibro scanning, and nurse-led assessment and same-day prescription versus business as usual. That's the Pivot study, which in essence showed it's just way more efficient to go with a point of care test on new entrants into the prison. And in that same seminar, I think there will be discussion about the fact that there is a Commonwealth project that looks like it's going to come to fruition soon, actually, to both scale up point of care utilisation in the community sector, but also in the prisons. In the prisons, my sense is it's most likely that the pointy end is really on reception. That is, of the 110 or so prisons in Australia, I think about 20 or 30 are what are called reception prisons. That's where individuals come from the community or from the police cells into the prisons. And that would be the right venue, it would seem, to try and get what we'd call universal opt-out testing. That is, everybody who comes through the door is offered a test, and if they say no thanks, it's okay, but everybody else gets a point of care test, either antibody and PCR or potentially straight onto PCR.
I might just throw it to Lise just to address, has there been any social science work that sort of looked into that concept of sort of opt-out sort of testing? Or we're not talking about mandatory testing, we're talking about trying to sort of engage more effectively in getting as many people tested quickly as possible and then on to treatment. Has there been any sort of work in that area looking at people's perceptions around that sort of rapid sort of notion of testing and linkage to treatment?
Yep. In the Pivot study that Andrew's leading, we did some interviews with people in prison around point of care testing for hepatitis C, and opt-out was definitely something that came up. People broadly felt that if you just offer testing at the point of entry or near the point of coming into prison, then that was the best approach. People felt that it was not too overwhelming to everything else that may be going on, but it allowed them to then prioritize their hepatitis C care whilst you're in prison. I think it's much preferred over other strategies. Catherine Jack in the UK has done research on this, and I think that was the findings in her work as well, was that opt-out was by far the best approach, and it enabled everyone to get tested in a way that wasn't stigmatizing, as we talked about.
Thanks very much, Lise. I think Adrian had to jump off. Is he still on? If he's jumped off, okay.
Yeah, he's gone.
So I think, Behzad, you had your hand up to make a further comment.
Yeah, Greg, just with respect to the other question referring to the 70% treatment in the SToP-C, I think it should be noted that coverage is actually in the context of the study with the dedicated nurses and dedicated the correction officers. If it is going to be a kind of standard of care or standard model of care, then it needs to with those human resources and the other support to be provided to the prison as well.
Sure, absolutely. Tracy, I might just sort of ask you around, we talked about the point of care testing with the platform that we may be able to sort of implement, particularly in a remand prison setting, but what about the strategy of dry blood spot and how that's sort of going in the context of broader screening for people who are incarcerated?
Yeah, sure. So, I mean, just so you know as well, we have actually invested in a point of care testing machine, and we've run a pilot at the reception centre at Silverwater where we tested 502 people over about a four-month period and found a prevalence of around about 12 to 13%. So we are looking at embedding point of care testing into reception centres around the state. It's just a matter of resourcing, you know, and finding rooms where you can do that. Our dry blood spot program continues, and we really like our dry blood spot program. The good thing about that is that we can go out into the yards. We don't have to have an actual room in a health centre. We can go out in the yards. We can do mass testing. For example, in SToP-C, we went up over 3 days. We tested 330 prisoners in 3 days. Again, we had a prevalence of around 12%. But it allows us to be able to do mass testing, you know, across numerous sites over a few days. And it's the big point of our hepatitis in prison elimination program, is to use the dry blood spot and to run some health education, harm reduction sessions alongside when we're doing that dry blood spot testing. So I think to date we've done, I think it's around about 3,800 dry blood spot tests. So yeah, we're really utilising it, and again, I think you know, we're using it way more than anyone else in the community.
Thanks very much, Tracy. Look, I don't know, I think, just to reiterate, I think both screening strategies absolutely have a role, and they may be employed in different settings. A question from Anonymous: is prison injecting mostly just opiates, or are there people who inject other drugs, for example, stimulants? Is it responsible in the context of this to set a target for OAT prescription as a proportion of people with a history of injecting drug use?
I could try, Greg. Behzad might actually have some data. I can say, though, from the point of view of our previous in-prison surveillance of injecting drug using patterns in the HITS cohort, and I think this is also true in SToP-C, the most commonly reported drug of injection are opioids. It totally depends on supply and demand, you know, so in circumstances where diverted buprenorphine or methadone aren't available, it could change the picture substantially. But for all sorts of reasons, it's opioids injecting that predominates. A minority of individuals have mechanisms to gain access to stimulants, to methamphetamine or whatever, but it's a minority. So the opioid dependence and its management more broadly is really the big ticket topic to reduce injecting desire and demand.
But I think even in the context of SToP-C, we saw some differences from prison to prison, even within the opioid sort of class, and you know, what was being injected.
I think it is important. It is opioid still the most frequently substances, but not specifically heroin. We have many participants in SToP-C who reported injecting methadone.
And Andrew, just sort of flicking back to you, do you think there's any different issues in terms of the type of opioid that's injected? I mean, are there other explanations for that? Are there different sort of strategies that are required? Is opioid agonist therapy sort of the way to go, irrespective of what opioid is being injected?
Oh, that's too hard a question for me, Greg. I'm not much of a drug and alcohol guy. The only thing I would pick up on is just that I think it's somewhat unhelpful to, within the prison context, in terms of drug and alcohol management and OAT therapy, to think of the individual, or to notionally classify the individual substantially on the basis of behaviours that happen in the community, because they change a lot. Even in the HITS cohort, we showed that the individuals who report lifetime injecting drug use, they cycle in and out of current use while they're in prison. So I'm much more of an advocate of a sort of an expediency approach to manage the prison-based injecting risk, because it's such a high risk of transmission of bloodborne viruses, on its merits. And a second order concern is to think about how it might be transitioned into the wider community for that individual and more generally.
Thanks, Andrew. There's a question from Belenu Tay. It's a PhD candidate at University of Queensland. How do the lessons from elimination in prison setting translate to elimination in culturally and linguistically diverse communities. So are there broader sort of implications for what we've been able to do in the context of a marginalised population in a prison setting for other sort of vulnerable or marginalised populations in terms of Hep C elimination?
Gee, that's interesting question. It's a sad truth, to be honest, that both our Indigenous community and other minorities, ethnic and cultural minorities, are indeed overrepresented in the prison. And while that statement remains accurate, it does therefore represent one of the small positives about putting people into prison, which I'm not an advocate, but in that context, healthcare provision sits right up there as one of the potential positives about an otherwise pretty negative experience. And so my sense is that this study and the elimination tries to turn what is a negative, so that idea that when we put members of our society into prison, our primary purpose is to remove their liberty, but not to secondarily punish them with some extra psychological, physical, or other health injury. And when we allow high rates of transmission of, say, for instance, hepatitis C to propagate in the prisons, that's a breach of our social responsibility. And so this study helps to start addressing that, along with potentially better, improved harm reduction strategies more generally, to minimise that secondary insult and maximise a health benefit outcome.
I suppose the other things that I sort of take from SToP-C that might be relevant is that we've demonstrated that if you resource things properly in terms of the people on the ground to do the assessment and help with the treatment provision, you provide a communication strategy, you have the involvement of peers, you really put this concerted effort into a particular community, it has favourable outcomes. And I think you can translate that into other sort of communities in other settings, I suppose. That's what I take from it.
There are data, aren't there, Behzad? There were a significant, approximately 1 in 5 of the inmate population are of Indigenous background, and another 5% maybe in total of other culturally and linguistically diverse backgrounds. I'm pretty sure they are well represented in the treatment uptake, is what that would be a positive thing to say. Sorry, Stuart.
Thanks, Andrew. Yeah, just backing up what you said, Greg. And as a preface, I also want to note that while I'm a member of the Justice Health Board, I'm not here in that capacity. I'm here as an independent community advocate. And I also sit, just for general interest, I've been on the board of Community Restorative Centre, working with people coming out of prison for the last 20 years. And I currently serve on 2 harm reduction committees, one in New South Wales, one across the country. I think the biggest comment that I want to make is the excellence and the well-resourced excellence of the SToP-C study versus the ongoing complexities of the real world. And it's that resourcing issue. Everything worked incredibly well in SToP-C. It was a brilliant study. But we've still got major barriers to the whole concern of hepatitis C prevalence and incidence in prison, going out, coming back in again. So I just wanted to focus and just get a word in for a continuing greater focus and a strong push for improved harm reduction services. At the top of the pile, we need needle and syringe programs in prison, without a doubt. We know from the reinfections that they would probably be reduced if we had NSP in prisons. We've got the current inefficient FinCol versus bleach sachets, which are used in Victoria and in the UK. Now, we're working in that direction, but we need to speed up that move to get better cleaning equipment, better cleaning procedures done. And I was expecting to see Luke Grant on this panel, and I was hoping he might be able to comment, but I don't know if Luke is here. He's Deputy Commissioner of Corrective Services, New South Wales. But we understand that there are new X-ray and other scanner machines coming into prisons, which will keep out drugs, but nothing that is introduced is going to keep out drugs completely. We know how they get in. They've been reduced through COVID, obviously, but they will come back. So NSP in prisons is a vital thing we need to focus for. Another consideration is the through care, people moving from the community, from prison back into the community. So do we have programs within Justice Health to support people if they have either not completed treatment or if they have not started treatment in prison? Are there some linkages within the broader community outside to facilitate people with Hep C leaving prison, going back into the broader community? But I've got a direct question for you, Andrew. It's really welcome to see the SToP-C implementation toolkit. What are the plans for rolling out this toolkit and making sure it is implemented both in New South Wales and in other states and territories? Is that something that the national group is looking at? Because it's a great thing, but to have it not implemented, not rolled out, not scaled up would be a waste.
Yeah, that's a great question, Stuart, and really a big challenge. From the point of view of the SToP-C study and its investigators, our goal has been to try and put every piece of information in place to instruct about how to do this endeavour and to make it widely accessible by website. We also are just warming up at the moment, a bit delayed by COVID, in a sort of a publicity campaign. I do know that there is already interest internationally in the study outcome and in the toolkit and how it might be applicable in other of the more socially minded prison settings, like in Spain, for instance. So my hope is that we'll get a groundswell to push it's an advocacy discussion, is it, to push the authorities that control the purse strings to better support the infrastructure to deliver. Sooner or later, my sense is that most developed countries will realise they will not eliminate without managing the prisons. And so the SToP-C provides a model to how to potentially push that agenda forwards.
Look, we're pretty close to time, so I think that's a good sort of note to end on, in the sense that SToP-C has shown us what can be achieved. I think there's no doubt that New South Wales has been a great leader in terms of providing access to hepatitis C treatment in the prison setting, and Australia leads the world basically in terms of these strategies. So it's great to have this session to discuss a whole range of issues around SToP-C and related sort of work that's happening in the prison sort of setting. So I'd really like to thank all the presenters and the panelists for what's been a great seminar today. Thanks everyone for attending, and happy World Hepatitis Day for tomorrow.